Next speaker is going to be Patrick Maloney, and he will be talking about spine trauma and deformity intraoperative imaging and assessment.
Good evening, everyone. Thanks again, Chris Vdara, for the invitation. It's a pleasure to be speaking up here. I was a former fellow at UCSF and have a part-time faculty position at UCSF where I get to do some of our more complex cases. My main shop is at North Bay Hospital, which is halfway between Sacramento and San Francisco, the hinterland, so to speak, where we do collect our fair amount of trauma and interesting cases. And then I have a small practice at the VA with the Air Force Base as well. Here's my disclosures. So, when I was a resident, spine trauma was, you did it. Yeah, you just kind of, didn't have to be perfect, but make it work. And it felt kind of like the island of misfit toys for spine. There isn't much, literature defining spine trauma and deformity per se, but in general, traumatic injuries of the spinal column are a small portion of all musculoskeletal injuries, but they bear a disproportionate share of the patient to the costs, especially with concomitant spinal cord injuries. So there's roughly 7,000 to 10,000 of the 50,000 cases are spinal cord injury. And again, with the long-term consequences and health-related costs associated with the acute injury, as well as spinal deformity considerations post-injury and post-fixation, I think it's an area of understudy for our spinal deformity colleagues. So the scope of the problem. Most spine modern systems, in terms of dealing with acute trauma, have guidelines for stabilization, the ABCs, ATLS. Most of us have to have accreditation to some degree to get privileges at hospital, which were some basic stabilization techniques for early patients who have, in the early injury period, have polytraumatic injuries. So as we've improved these, and these are now widespread, and there's different accreditations for level 1, level 2, level 3 hospitals, there's a coalescing of triaging these patients, and we've done better as far as recommending who needs to be treated acutely versus what can be delayed. So greater number of patients are surviving from these, and there's a more aggressive techniques available to stabilize them acutely. So when they looked at it for the SRS, there was about a 6% representation of traumatic injuries in the database. Complication rate and mortality rates were relatively low, and it was interesting, fusion wasn't performed in all cases based on the data. Most common complications for mortality were related to respiratory, and we'll go over some of those cases. So the other area is, often traumatic spinal classification systems are used to treat operatively, non-operatively in the beginning. There's been a couple reviews of these showing that, in general, the maneuvering towards early mobilization with a spinal orthosis does probably underestimate longer-term development of kyphosis. This one review had patients that were treated both non-operatively and operatively had progression of the kyphosis, and even in fusion patients. Patients that were treated with a fusion had less progression of the kyphosis, but it still did occur. This is just a classic L1 burst fracture, one treated operatively, non-operatively, where there is progression over time of focal kyphosis and independent of the vertebral body comminution. So, the current state, there are no really agreed upon definitions for post-traumatic deformity, but in general, if it's a surgery that requires an extensive treatment to deal with both deformity as well as the acute injury, and then separating the symptomatic versus asymptomatic when dealing with trauma. But there's really not a clear-cut definition in the literature that we can use to coalesce some of the research around. In general, though, when you do have to fix post-traumatic spinal deformities, often you're employing both anterior and posterior techniques, complex osteotomies, especially in cases where there's been ankylosis or fusion of vertebral levels with high kyphotic angulation, and then the ever-present what to do with the posterior ligamentous complex at the early stages and how to evaluate it over time in its chronic state to see if it is going to continue to progress over time. So just a case example, this is a pretty standard patient that we would have come in. This was a pedestrian versus motor vehicle. He had multiple fractures and an unstable cervical thoracic 3-column injury. It's hard to appreciate on the table due to alignment of him being flat, but he has complete disruption of the lamina bilaterally. Laminar fractures extended up to C6 and C5. And so we put him in a collar. He had multiple fractures of the ribs and sternum as well. And so stabilizing hemodynamically from a respiratory standpoint, the first 24 hours, he just stayed in the ICU in a collar, and we saw him the next day. Just to get an idea of the severe facet fracture dislocation and almost complete subluxation at the cervical thoracic junction. He also has, as often, patients with high velocity injuries, other spinal fractures, in this case an L1 burst fracture with some canal compromise greater than 50% loss of height. So again, there's various classification systems. We don't have to go over those in detail, but the AO has several. Probably the most common used for thoracolumbar and cervical, the SLIC and the TLIX, which is usually just to help us decide which cases need to be stabilized acutely surgically. And then again, his other injuries, he had a flail chest with separation of multiple ribs from the sternum and then a broken clavicle. So there was concern of positioning him prone for a front-back spine case. So meanwhile, in the ICU over 24 hours in a collar, when we send him for a CTA to get his verts and assessed, he's completely subluxed, and C7 now is sitting in front of T1. Interestingly, he was still able to, on sedation, wiggle his arms and wiggle his feet, but obviously there was concern for neurologic injury. So we did closed reduction in the ICU, got pretty good reduction of the fracture, again, highly mobile. I think we did this with roughly 50 pounds to get him to that state, and took him immediately to the OR for a supine procedure. And again, trying to fix a highly unstable injury with a long construct, elected for C5 to T2 anterior cervical fusion. And we were gonna delay his posterior fixation a day or two at least to be able to restabilize. Eventually we did get into the MRI, just showing a large epidural clot at the L1 level where there's a fracture, poor image quality at the cervical spine, but no obvious T2 signal change or other compressive epidural hematoma that needed to be evacuated. Ideally, you would have an MRI at the early stages to be able to decide if a laminectomy or something in addition to a fusion needs to be done to evacuate. So 2 days with in the ICU while waiting for posterior stabilization, we get a repeat CT, and he's pulled out the hardware at T1 and T2, and essentially having a repeat of his spondyloptosis at the cervical thoracic junction. So we put him in traction again, same amount of weight. We're able to get successful reduction. And at this stage, using an expandable corpectomy graft, and then we used multiple bolsters for the chest to be able to ventilate. And we didn't have terribly high peak pressures. We were able to fixate both anterior and posterior at the time from C2 to T3. And then at that same setting, in order to mobilize them, these patients are going back and forth to the OR a lot of times. We'll always use an IVC filter if we have to hold chemical DVT prophylaxis, and just did a posterior only 2 up, 2 below for his burst fracture. So lessons learned for the case when we reviewed this, we talked about possibly doing rib and sternal stabilizations to be able to position a patient prone for a long spine case, especially if there's going to be concern ventilating or issues for his cardiac output during the case. There's been some descriptions of doing rib stabilization procedures for this to have patients positioned for surgery. He had a long hospitalization, obviously. We did not get him out the same day, but a little over a month, even after trach and peg and multiple trips to the operating room, he was able to be discharged. So I was surprised to see him about 6 to 8 months later, shows up in my clinic, and he's ambulatory, he's independent. He's about an Asia D, but his most severe areas deficits are a bilateral foot drop. But he did arthrodese, the hardware above and below in the thoracolumbar and cervicothoracic was intact with early bridging fusion mass. CT scan and MRI scans showed no severe neural compression with the exception of his L4-5. So pretty symptomatic severe stenosis with a grade 1 spondylolisthesis. And so now for his bilateral foot drop, we're going from a patient who survived a multiple polytraumatic spinal injury to now he's a deformity patient. And so how to address this while incorporating what has been done previously. I think, when you treat these patients acutely, you're not thinking about deformity correction. You're thinking about getting them through the initial injury, the operative stabilization. But this is someone that we're going to be planning to do probably T9 to pelvis to help with his sagittal alignment. And I think, intraoperatively, knowing what he was before, he does have a little bit of coronal deformity in the upper cervicothoracic. So when we, fixated that area, we may have given him a little bit of iatrogenic coronal curve at the top. So in general, for spondyloptosis, these cases are fairly rare, but in the literature, they are borne out usually at the lower cervical spine. So C6-7 and C7-T1 are the most common areas. Traction is almost universally applied before surgery. Typically, because that level is several subaxial segments below, you're going to be working in the 50 to 40 pound weight range for reduction. And many patients, although many can have spinal cord injury, combined approaches and being able to achieve at least an ASIA D or grade better is possible with early intervention. A couple other areas in terms of spinal deformity and overlap were how to approach C1 fractures. Typically, these are not common injuries, but they do occupy a higher incidence in our frail elderly patients. They can incorporate injury to the vertebral artery, blunt vertebral artery injury, and collar mobilization is by far and away the most common initial stabilization for these types of injuries. And obviously the key arbiter of whether or not someone needs surgery in the early stages is whether or not the transverse ligament is intact. Again, multiple classification systems delineating both atlas and axial type injuries. But for the most part, there's a lot of ambiguity when it comes to treating both C1 and C2 fractures. There's not an optimal course. In general, though, often spinal orthosis is applied in the early line. So when I see the patients, I usually see them, after 3-4 months of treatment in a collar, and there's been progression of, the deformity. And in this patient, 80-year-old, has, separation of the C1 lateral mass, and she had severe occipital pain and some cranial settling associated with this. So most of these patients are neurologically intact. Again, the vertebral canal, the spinal canal is pretty capacious at C1, C2. And, redemonstration of a ruptured transversal ligament sometimes can be called on an MRI, but in many instances it can be ambiguous of whether or not there is true disruption. So looking at markers in terms of the CT and the rule of Spence are classic indicators of whether or not stabilization needs to occur. And then obviously evaluation of the vertebral arteries, ensuring the patency as well as dominance. For these patients, getting an MRI acutely sometimes can be difficult, but in general, the rule of Spence can miss up to 60+% of injuries. So that is I think, a failure of some of the classification systems as well as what we use to screen unstable atlantoaxial injuries. So it is an injury that can progress over time and be subtle of whether or not there is true disruption. So because of her multiple areas of ankylosis above and below, elected for a longer construct and a typical C1-2 fusion to treat. She had good resolution of the head and neck pain. Similarly, a similar case, another chronic C1 fracture with cranial settling, in this case a widening of the atlantodental interval. This patient had been treated in a collar for 8 months with recommendations to remain in the collar for life, that she would be too high risk for surgery given her age and frailty. This was a case that we're able to achieve nice reduction intraoperatively with the Mayfield head holder using some distraction extension and then fitting around her previous lateral mass construct and using cervical W screws. We're able to avoid also going to the occiput, which is always a risk. And then the last etiology in terms of spinal deformities that we see is the the ankylosing spinal disorders, typically DISH, ankylosing spondylitis, as well as patients with end-stage spinal disease. This was a patient also in the 80s, had a fall from or golf cart crash and a clear C6-7 fracture dislocation, and similarly, again, multiple spinal injuries with a bony L1 trans fracture. So we're able to take this patient to the operating room immediately, and in this case, early stabilization with screws helps the patient mobilize, so elected for both a posterior and anterior surgery in the same anesthetic setting, which he tolerated well. We were able to maintain him in a collar post-operatively. Again, he has high thoracic kyphosis in the upper thoracic levels, but we're able to, for the most part, achieve some modest correction through his fracture. So delayed posterior fusion to augment the anterior construct 2 days later, just 3 up, 2 below. And then about 2 weeks after, as he's rehabbing in the hospital, he starts having increased dysphagia as well as some right arm pain, and we noticed some screw pull out at his construct at C6-7. So we took him back to the operating room, put in an expandable graft, and did a partial C6 corpectomy, and were able to revise only the anterior portion of the construct in order to achieve a harmonious construct. So he did very well. I've been following him for a little over a year, and he's repatriated to another health system, but otherwise has not required any other revision. So when evaluating patients with ankylosing spondylitis, DISH, and end-stage advanced spondylosis multiforme, these are patients that can have highly unstable fractures due to the long moment arm of many fused vertebral segments. And so they often have multiple fractures during the initial evaluation, and they should be treated aggressively with long constructs. In general, for ankylosing spondylitis, in terms of prevalence, vertebral fractures for that specific population is high. You only have to make the diagnosis for radiographic criteria now. We don't have to send for the HLA-B27 lab reports. Hyperextension injuries are the most frequent mechanism of injury for these fractures, and they do have a high rate of spinal cord injury. So in conclusions, for complex spine and deformity, will continue to overlap, especially as these patients survive their initial injuries and stabilization procedures. Whether it's non-operative or operative treatment, patients need to be followed for long-term because they can develop deformities as a result of initial stabilization and treatment. Highly unstable injuries can require multiple approaches, especially in the same hospital setting, to achieve a durable spinal construct. And then again, concomitant injuries in terms of other polytraumatic injuries that are struggling with during the hospitalization may affect your timing of whether or not they can go to the operating room early. Early is generally better, especially in patients though with spinal cord injuries, from our trauma guidelines. And then, in terms of evaluating deformity, whole body x-rays in general are not available in inpatient setting, but achieve, early outpatient follow-up to understand where the construct may fail, especially in the immediate and long term, I think is important in being able to prepare these patients for a delayed spinal deformity surgery in the future. Thank you.